So Voyager PAD was a trial, quite a unique trial that was designed to look at patients with peripheral artery disease undergoing revascularization, the acute revascularization period, and randomize them to rivaroxaban 2.5 milligrams twice daily or placebo on a background of antiplatelet therapy. And overall, it showed that rivaroxaban would reduce or reduced irreversible harm events of the heart, limb, and brain. And there was more bleeding, but overall, a net benefit. Now, this data led to the approval for this indication, but for clinicians, there are a lot of questions about which patients to treat and when. Overall, we've found consistency, but one subgroup of patients is the group of patients who are at higher risk of bleeding. Sometimes we call them patients who are fragile. That's defined by some characteristics, age, renal dysfunction, low body weight. But those are patients where clinicians often have a hard time of deciding whether the benefit risk favors treatment or no treatment, and oftentimes they're undertreated. So we thought it was important to look at this subgroup of patients. For this subgroup of patients, we found that not only were they at an extremely high risk of ischemic events, but when we looked at, rather than just first events, the total number of events, including recurrent events, that out of 100 patients for 3 years, there were 99 events. It's an astronomical event rate. And so these are very high risk patients. We also found that they were at higher risk of bleeding overall, and that's not unexpected. That's been seen in many observational data sets. But then when we looked at the benefit risk of rivaroxaban, it was very interesting. There was a very big benefit, and particularly for limb outcomes or major adverse limb events. And while there was more bleeding, it wasn't more bleeding than the trial overall. So when we looked at this population, it was a large subgroup. There was a favorable benefit risk ratio, even in these patients with low body weight, renal dysfunction, or the elderly. And so we see consistency for a favorable benefit risk ratio. It's interesting. We also saw that there was more drug discontinuation, even in the absence of adverse events, which really talks about some of the behaviors for physicians and patients to de-escalate therapy in this population. But much like atrial fibrillation, we find that there is a strong data set now that supports treatment, obviously with shared decision making. I found it really notable that although bleeding is bad, that the bleeding events we saw with rivaroxaban were not fatal bleeding events, not intracranial hemorrhages, nor did they offset the benefit that we saw in ischemic events. So that we, I think, emotionally always worry about the harm that we cause as clinicians, but here, under treating, I think would cause more harm. I think the other issue that came up to us as we did this analysis was that there was a recently published Beers criteria, which looked at different DOACs for atrial fibrillation, favoring some over others. And what was striking here was that for this indication, for patients with peripheral artery disease, there is only one drug at one dose that's approved. That's rivaroxaban 2.5 milligrams twice daily. And if people were to get confused and these elderly patients or fragile patients thinking of favoring other drugs at other doses, they'd actually be overdosing these patients. So, Pixaban would not be a good choice here, or dabigatran. This is really very specific to the low dose of rivaroxaban. Yeah, I think a key takeaway is that patients with vascular disease have a lot of recurrent events, and that we have to think about the totality of the burden of disease. If you care for these patients, you know it, that the first intervention is rarely the last thing that happens to them. There are a lot of recurrent events, and so we need to look at that. The second thing is that patients who are fragile, you may worry about bleeding risk, and I think that that's important as we discuss shared decision making. But like atrial fibrillation, I think that the benefit of treating, at least in this data set, outweighed the harm in terms of bleeding. And so we shouldn't undertreat. And the third thing that we learned is that adherence and sometimes de-escalation are factors as we think about patients who are elderly or with renal dysfunction. And it's really important to think about ways to optimize adherence and to really engage patients in understanding the benefit risk of the therapies that they get.